So, having said all that, thank you to Dr. Zwelling, Congressman Sessions, and my session chair, Dr. Wool, as well, to everybody for being here and putting in the time to try and make the best possible effort here in Washington, certainly. So, we're going to talk about principles for healthcare freedom and individual choice in healthcare, and maybe I can give you like a little point or something, so let's go ahead with that. Thank you. So historically, healthcare was really simple. It was a doctor, a nurse, another healthcare provider of some sort, and a patient. And it was time spent in the room, and it was private. And now, this is your new healthcare system after 2010. You notice that it all revolves around the federal government, basically. That's the schematic. And I thank Dean Clancy, who's my favorite policy wonk in the entire world, from Florida for that. So the good old days, health insurance was an irritant, but not a nightmare. If you had high premiums, you had low deductibles. If you had high deductibles, you had low premiums. Now we have high premiums and high deductibles. Sweet deal, says Victor Littman in Forbes. And of course, you know the three promises that were broken time after time, like your doctor, keep your doctor, like your health plan, keep your health plan, and we're going to lower your premiums. And a lot of us saw premiums double over the last 5 years. Next, please. So I'm not going to go through the 10 problems that are here in detail. Even the co-ops that we paid taxpayers, 1.7 billion would it be? 19 out of 23 failed, and the rest aren't doing so well either. So it was a huge, colossal waste of time and effort. And it was passed by one party. And no offense, but there has to be some consensus for major tax laws in this country. Next, please. Okay, I have a 70-year-old Irish patient because it was just St. Patrick's Day. He came in for his annual physical, and I said, "How are you doing, sir?" He says, "I'm on the right side of the green, young man." So I thought that was great, absolutely. You don't want to be pushing him up. You want to be stepping on him or walking around him. But I said, "What do you think of the new possible partial repeal, partial replace plan that they've presented in Congress to vote on this week?" He said, He said, it's half a loaf. And he said, it's stale at that. So I thought that was quite interesting from this interesting patient that I had. So we need to work a little harder. We need to get either more included in the plan. And I know how impossible everybody tells us it is. But, you know, iPhones were impossible too. Television was impossible. Everything's impossible. And in Washington, it's impossible times 100, I'm sure. But we've got to do more. Of more than what's possible. We got to do what's necessary. And you can quote me if anybody wants to take that down. So having said all of that, if we don't have the votes, the 60 fabulous votes for full repeal, perhaps we can nullify it or reconcile it because it was forcibly enacted, you know, with no bipartisan support. It was changed by the executive branch 43 times. It was changed by the Supreme Court to be a tax bill. And tax bills have to come out of the House. They can't come out of the Senate, and this bill came out of the Senate. That's not legal, and it's not fair, and no offense, but we have to be a nation of laws. And if one side's got to play by the laws, the other side's got to play by the laws, especially when this side's got 51 votes. So, at any rate, very, very important. So if we could move on to the next slide, please. Adoption of expanded HSAs, which we've heard here time and time again. People have to be able to buy their medicines, their over-the-counter medicines, even their primary care DPC, or paying their physicians, because that's a competitive environment. Patients get to see what they're paying, they get to make choices. What if I asked you if you wanted to buy a car, and I wouldn't tell you how much it is? Well, you wouldn't buy the car. Of course you wouldn't. You need to know how much it is, and you got to make decisions, and HSAs are a great way to do that. In fact, HSAs are so fabulous that because the government made them available, they've started to catch on. Unfortunately, federal legislation hasn't been wide enough to permit it across the country, so we need to work on that. And there's a good article by Rob Berger in Forbes. Next, please. Adoption of true individual high-deductible plans not coupled to the employer. That's where Congressman Sessions and I disagree. I think the individual market needs to be robust, and everybody needs to be able to buy and compete, whether it's across state lines or not. Because when it's coupled to your employer has different needs and wants than you do. And your union has different wants and needs than you do, assuming you have a union, but we're not allowed to have them as physicians. Seems like everybody else does, but whatever, whether you're union politic or not.
Name one state that you would want to buy from.
What do you mean by I would want to buy in? Help me understand.
Name one state you want to buy your insurance from.
Well, I live in New Jersey. If there was a reasonable New Jersey plan like basic and essential, I would certainly buy it, but it's not available any longer.
How about HSA?
I currently have an HSA. Yeah, but the thing is if you're paying $20,000 for the premium, you should be paying $10,000 for the premium just to cover the big ticket items and the hospitalization. The small stuff we can work out. I mean, we can get labs for dollars, not hundreds of dollars. In fact, a lot of DPC practices can get a lipid panel for $5 if they draw it themselves. If I send to a local cash lab in New Jersey, it's $19. And if I send it to the hospital, $450 with a $50 draw fee, and they'll send you to collections. They'll write off the debt, and they'll say, oh, but we're not-for-profit taxpayers, you got to pay us.
You're trying to help me get there, so why would they rate what you're doing in Montana as opposed to New Jersey?
Well, that's a question. I mean, there's an issue with state rights, and I mean, you know, it's
that's where you actually get it. That you can't get your health care in Montana.
Correct,
it's like car insurance. You could buy it in Rochester, but you're in Miami.
Right.
Miami rates. That's how they're going to rate you.
Right. Well, if you're talking about healthcare itself, I live at the border of 3 states. I live in southern New Jersey. I can go across to Philadelphia if I choose. I can go to southern or northern Delaware, which may be cheaper because they have tax benefits and things there. When it comes to insurance, maybe I'd want to buy from the 3 local states also. But I mean, that's a big discussion with regard to across that. So I'm limited to 10 minutes, but I'd be. What would you say? I'd be happy to talk to you about it afterwards. If you want to text me, and I can visit your practice if you'd like. I'd be glad to do that for you, sir. And I appreciate you being here for us and playing devil's advocate. It keeps us all honest.
I think that's a question.
No, absolutely. So, as I mentioned in my last presentation for you guys several months ago, we talked about between 1939 and 1943, the War Labor Board and the Revenue Act of 1939 made employer health insurance reality because it gave it a tax treatment. And because it rolled back the taxes on that stuff, by 1960s, almost everybody had employer-sponsored health. So the way taxes are treated is the way the country goes. And that's a big issue and why we need a full repeal. And we were talking about that. Can we go to the next slide? Thank you. Insurance without networks that don't discriminate against physicians and healthcare facilities or limit plan or subscriber options. In fact, Senator Patrick Colbeck of Michigan Informs wrote about a free market healthcare revolution, why and how, and he used direct primary care as an example because you can buy direct, and if you can get reimbursement either from your HSA or from your insurance, that frees you up. And we had also talked about balanced billing and those issues, which we'll certainly address later. But insurance should be paying patients back, not contract physicians and other facilities, because I don't know about you, Aetna pays me X, and they pay Huge Monster Practice 2X. And Huge Monster Practice doesn't do necessarily a better job than I do. Maybe they do on some things. But why 2X versus X? Because of contracts and negotiations, which, it doesn't pay the patient. It doesn't behoove the patient. Next slide, please. Medicare reform. We have to work toward the repeal of MACRA. And I know everybody said MACRA's not going anywhere, MACRA's this, MACRA's that. Well, we've got to work again toward the necessary and get over the possible. So until we can do that, as Dr. Zwelling had said, we can get small practices opted out. Right now, of MACRA, practices with less than 100 Medicare patients are opted out. And we have never... I have never known a physician to have less than 100 Medicare patients. In fact, last time I had the privilege of bringing on a Tennessee backwater doctor who was just charming, who hasn't taken a paycheck in 6 months. She extricates her patients from the car, brings them in, takes their blood pressure, calls them, and does everything that needs to be done, and Medicare withholds her money. It's just incredible. She could never comply with MACRA, and guess what? She's got 200 Medicare patients. So she's not opted out, and she's already broke. I mean, how much more broke can you go besides broke? And then at that point, she can't serve as a physician, and that is definitely a problem for the country. So we need to start, as Dr. Zwelling said, with larger practices, up to 10 physicians and perhaps 10,000 patients. We need bigger numbers. We need to get a lot of more people under the fence until we can get this completely repealed. We have to stop the high-tech EHR bad faith audits. The government giveth and the government taketh away. That's exactly what happened with meaningful use. Do everything we want, jump through all the hoops on your evenings and weekends, and we'll give you $16,000. And then at that point, 5 years later, come claw it back from you. And I was actually audited by my EHR company that I've changed EHRs twice since. The old one, the company abandoned. They're a company in Texas. I probably should talk about that with the congressman. They abandoned me. They said, I'm sorry, we can't help you. And I had to pay them for hours of assistance on it, and they said, sue us. We're not going to help you. So the minute you get something from the Treasury, and you get a bill that says U.S. Treasury, and says, how would you like to pay this, now or through the nose? No, thank you. No, thank you. I don't want to be part of a system that's going to hold me responsible to things that I can't possibly do for a decade. And that's what MACRA does, and that's what EHR, meaningless, useless audits are doing. And it was always planned. I mean, if you read anything that they've written on, it was always planned to come claw back money. Next one, please. Allow and simplify private patient contracting with pre-tax dollars. This also goes to HSAs. Where in Medicare and Medicaid, don't make it so hard to charge the patient directly. If we're charging the patient directly, the government's not paying, the insurance company's not paying, the patient's paying, and they're the ones who should be paying. And they get a competitive rate. They have the most negotiating power at the moment of sale. You try to negotiate a sale after you bought the car? Of course you don't. You go in and you're prepared to leave the lot if you need to. I'm sorry, it's cheaper down the street. Have a nice day. They come running after you. So, and one could make the argument with big ticket items, like hospitalizations and stuff, that might not be possible. With primary care and most physician care and most clinic kind of stuff, it's absolutely possible, and it can happen every day. And the Medicare website also is against physicians. It says, make sure your doctor, provider, or supplier accepts assignment. It says to them on their website, you don't have to sign a private contract. You can always go to another provider to give services. So basically, they're chasing our patients to urgent care. So they should get, the clinic set up with absolutely no follow-up or responsibility or relationship. Next, please. Allow balanced billing in all government programs, including Medicare and Medicaid. I love to see my Medicaid patients. I say, $75, I'm happy to see you. I'll spend the time it takes to do the job. I can't do it for $19 and provide an interpreter. It's just not realistic.
And you don't want it, maybe go somewhere else.
Exactly. If I'm the right guy for the job, I'm here for you. If I'm not the right guy for the job, that's fine. There's other guys and girls that do a job that may be to your liking. Having said all of that, there should be balanced billing. Next, please. Allow individual physicians, healthcare facilities, and patients to determine which form of healthcare record-keeping systems are appropriate. In fact, the Citizens Council for Health Freedom, we have Twyla Braves here, who's spoken with us many times in the past. I've had the privilege of being on the dais with her before. She talks about the dangers of America's medical record system that the government forced us on, and the unsecurity of healthcare.gov when that was all rolled out and laughed off. But frankly and honestly, it's worth a lot of money on the internet, ladies and gentlemen. And this is my paper record in case the electronic record doesn't work, which is about 1/10 of the time in my office. Next, please. All patient data, whether demographic, financial, health, or otherwise, must be private, secure, and sacrosanct. Because just as Congressman Sessions sat here for the doctor, and unfortunately they didn't have much time for examination and history taken, which, that didn't add to the quality. Well, it did to the government. The government got all the boxes, and he didn't get paid for that, which isn't the way you would do it as a person, and that's a big deal. That is definitely a big deal. But all data must be private. When you go into the doctor's office or wherever you get your care, it must be private and live there in the office unless you say otherwise. It shouldn't be submittable to insurance companies by demand. It shouldn't be submittable to third parties, and you shouldn't have to provide it for prior authorization. That's none of anybody's business but the patient and the person that they trust. Care entities do not provide care. They should not be allowed to limit care. Next, please. Block grant Medicaid back to the states. It's interesting. They're all supposed to be states. Each Medicaid is supposed to be done differently and things. And the way the Fed has it set up, the Fed rakes in all the tax money from everybody and says, well, we'll give you 50% of your program if you do what we say. Well, then the Fed is controlling it. Maybe there's a different a different solution for Missouri than there is in New Jersey, or for Texas, or for Florida or California. Maybe there's different ways to do it. Imagine if we had 50 different types of payment systems for Medicaid going on. What an incredible experiment in a scientific method that would be. And maybe the top 3 will work. Maybe. Maybe there'll be 1. Maybe there'll be none. We got to start over, but each state should have their right to do it, and it shouldn't be the Fed. So we need to block grant that back to the states. There's a good article reference at the bottom in case the Congress decides not to do that there are some possibilities for states themselves. Government must not interfere or put asunder patient-physician relationship or healthcare delivery in any way, shape, or form. It violates the original Medicare charter in 1965, and I'm going to read this verbatim. The prohibition against any medical interference reads as follows, Section 1801. Nothing in this title, that is Medicare, shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine. And I argue, since 1965, that's all Medicare has ever done, is limited it. And that violates their own law. And we need to find a way to hold them responsible for this. They need to be responsible. At the bottom, there was actually an article in Medical Economics where I served on the editorial board for 7 years. Is MACRA legal? Dr. Louis Partsonis wrote an article. MACRA is not legal. It violates all of that. It doesn't. The government is not allowed to determine who gets what and when and how and who gets penalized when it comes to medicine. That's the 1965 law. Look it up. Talk to your legislators about it. Next, please. Physicians should be certified for lifetime after their residency and certification initially. Osteopathic continuous certification for DOs and maintenance of certification for MDs. There's a huge movement in the country right now against both programs because they're money-making programs. You've got a captive audience. You've got a captive audience. All physicians must do this, or you're going to be kicked out of your insurance, you're going to be kicked out of your hospital, you're going to be kicked out of your practice. Lots of problems occur, and it costs each physician thousands of dollars a year to comply with, and takes hours away from patient care. It takes time away from patient care, money away from patient care, and that's not acceptable. Even ABMS, that profits off of this greatly, recognizes, quote, regardless of profession, whether it's healthcare, law enforcement, education, or accounting, there is no certification that guarantees performance or positive outcomes, period. End of story. And our hero in this realm that put down maintenance of licensure in Ohio several years ago was Paul Kempen. You can, K-E-M-P-E-N, you can look him up at aapsonline.org. Next, please. 14, malpractice reform, and you can see he's the elephant in the room, because we were all told in 2010, and the AMA was told, Congress is going to change the malpractice game that's being played by putting in something, but nothing happened. Zero happened, and they got nothing. They got nothing for their advocacy for the ACA. Having said all of that, there's court limits, there's loser pays all, there's alternative dispute resolution, there's protections for whistleblowers, sanctions for expert witnesses that commit perjury. Basically, you have to reduce defensive medicine and cut out the payday gamble for big money payouts. In fact, there was a great article on Vanderbilt Law Review, Medical Practice Litigation and Tort Reform. It's the incentive, stupid. People are incentivized to sue. It's plain and simple. And it needs to be changed, and it needs to be changed on a federal level. Next, please. Congress must comply with whatever healthcare policy they pass for obtaining their own care. It would solve many of our preventable problems if they complied with all the laws that they pass. But, well, it's interesting. They are and they aren't, and that's a law. Okay. Go ahead. Congressman Sessions.
Members of Congress might have worked in the state legislature. They can still carry forward theirs. The senators might be on Medicare. If you're a member of Congress and you receive your employer-provided health care, it is and only is Obamacare. Across state lines, the gold plate. Okay? Period. End of sentence.
Okay. Well, I appreciate you sharing that with us.
Next question now.
Oh, I appreciate that. But Congress does accept itself from the following list of things. According to Theodoric Meyer of ProPublica, do as we say, Congress says, then does as it wants. The Freedom of Information Act, sometimes they don't have to comply with those.
That's right, we don't, because what I handle is private, a constitutional privilege.
Right, and I'm not giving
And
you-
likewise, my employees, they're at will. I can fire them and let go of them tomorrow because they work in the public interest. And so a normal company cannot do that really without cause or for some reason. We can do it automatically. We have people that do not belong in our business. I didn't say it's right, but I think it's the right thing. If you get a bad employee, you should be able to get rid of them because they can ruin your business and they can steal people's information and they can do things. And there's only an ethics requirement against them.
And I appreciate that, but in a private business that does healthcare, I'm not allowed to do that. It's very difficult for me to terminate somebody. No, I understand. I understand, and I appreciate the back and forth. So, I think that's the final slide. This is the updated slide deck. Together, we can make healthcare great and simple again. If we go direct to patients, with patients, for patients, we operate in their best interest. Their best interest serves our own. We give them the best care possible, they pay us directly, and they decide who provides their care and when. Hugely important. Thank you for your support, and I'm sorry that it was the end of the day.